All righty, good evening and welcome everyone. I am Lauren Gates, your host of this evening's exciting Airway Health Solutions conversation series with our own Dr. Ben Miraglia and Chad Rasmussen. We also have Dr. Kevin Boyd and Dr. Bret Christensen on our panel. We may have some other guests join our panel discussion later in our Q&A. So we are thrilled to be here, and it's actually due to demand. So thank you all for asking about Toothpillow. In fact, I saw a title on the World Dental Facial Symposium is "What the Heck is Toothpillow?" But I kind of like that title. But we called it the what, why, and how of Toothpillow. So there's been a lot of questions. There's been a lot of kind of maybe misinformation as well about what Toothpillow is and what it isn't. So we're excited to share with you, first of all, what it is, how we go about it, platforms, and Chad will go over that in a lot of detail of how you can get involved as an allied healthcare professional and as a doctor. So we're going to kick it off with a presentation from Dr. Ben Miraglia on the actual myofunctional appliance guides themselves and how he incorporates them into his practice. He's been doing this for over 30 years. And I don't know, how many cases have you treated? How many patients have you treated, or people?
Oh, it's been thousands. Yeah.
Yeah.
Thousands, and over 2 decades of using the guides. Yeah, it's been pretty amazing.
Right. So you have 21 years of interceptive orthopedic orthodontic experience, and your focus has been on early childhood growth and development. You lecture nationally on this, internationally, actually, and we are thrilled to have you here today to share with you the knowledge and just clear up maybe some of the mishaps or misconceptions that may be kind of buzzing around myofunctional appliances. I do need to do a couple of disclaimers and housekeeping items. Is that the views presented are the opinions of our speakers and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions or Toothpillow. The following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. And also about your CE, we are thrilled to offer everyone CE for this evening, but you do need to be in full attendance for the hour and a half. And we don't have a survey. We don't have any type of anything that you need to fill out. We do have the Zoom keeps track of your attendance. So if you are in attendance for the full time, you will receive a CE certificate. Give us 7 to 10 business days, and we really appreciate that. So I also like to see who's with us tonight. We had over 500 registrants, so thank you for your interest. We're thrilled to have you. Some people can't attend this evening, but they will attend for the recording. So welcome if we're on another day and time. But let's go ahead and take a quick poll of who we have with us. I always like to see which healthcare, allied healthcare providers we have and doctors who are attending with us tonight. So we'll go ahead and kick off that poll. And just please choose the best description. I don't think we have all of them available, but we did our best, but we want to get a feel. Share the poll. I don't have that control here. Not allowed to vote. So I don't know, Jay is my assistant tonight. Jay, can you share the results of that poll? Okay, yeah, there we go. Cool. So here we have, okay, you can kind of see, wow, it's a close call between the dentist and the myofunctional therapist. So maybe we'll have more guests, and the dental hygienist is right behind, followed by the speech language pathologist. And thank you everyone for taking the time. We have a few parents as well. So just so you know, this is a professional geared webinar, but we're glad you're here to learn more, and we're happy that you're curious. So welcome if you're a parent as well. So let's kick it off. Dr. Miraglia, you have so much to share with us. Why don't you go ahead and share your screen, and then we will resume. Chad, I'll have you as a follow-up, and then we'll have our panelists have a really robust conversation. So welcome, Dr. Miraglia.
Thank you. Let me get this. Here we go. Okay, did it share?
It did.
Fantastic. All right, myofunctional guidance appliances. So basically in the next 30 minutes, I'm going to build kind of a pathway to Toothpillow, and it all began over 20 years ago, starting to use the appliances for children between the age of 3 and 12. And so just for the images, that all of the images are original. They're, as they are without manipulation. You'll see some of them aren't wonderful pictures because I don't always take a nice picture, but we don't alter them, that's for sure. All right, the brief overview of guidance appliances, myofunctional guidance appliances. So they are removable myofunctional appliances that help train the muscles of the mouth and face to achieve optimal growth of the jaws and positioning of the teeth. They encourage proper tongue posture, lip closure, and breathing through the nose. When do I use them? Between 3 and 12. Why do I use them? Because almost all kids have soft tissue dysfunction and underdeveloped jaws. How are guidance appliances used? Basically, we do 1 to 2 hours per day plus overnight. So backing up to the why use them, it's to make it a very short story, the early soft diet is really the trigger for the soft tissue dysfunction. And with industrial Western living, the early soft diet has been shown in the anthropology research to be the largest source of the muscle weakness and dysfunction and the underdeveloped jaws. So malocclusion has a cause, and it is early soft food. So when the early soft food is introduced, the jaw muscles become smaller and weaker. And when the jaw muscles are smaller, weaker, and dysfunctional, we do not get full jaw bone growth. And if the jaw bones don't grow, well, then the teeth are crowded, but then the nose is smaller. And with the nasal cavity being smaller, and of course the tongue space being smaller, we have a smaller airspace or airway that's left behind. So early soft food, weaker dysfunctional muscles, underdeveloped jaws, bad breathing, bad sleeping, unhealthy child, symptom list. So all of that goes to build where the children are when we meet them at 3, in that they already have a recognizable form of malocclusion, in that they have a lack of spacing. So they have kind of crowded primary dentition with a poor bite already. So in my world, every child is a candidate for early treatment as long as they have some sort of visible malocclusion and or symptom list, in which case I would say it's almost all children have something to see or learn about in the malocclusion and or symptom list. So appliances, what do they look like? These are 2 examples of them. These are 2 of many. In Toothpillow alone, we have over 18 different styles and sizes to use on kids, but these just happen to be 2 different appliances from 2 companies that we source them from, so we can use them on children. But at first glance, they look like a football mouth guard. It looks like you could run around and play sports, but it is not a guard, it's a guide. And they are built and designed to redirect you to nose breathe, to redirect the tongue to the roof of the mouth, and for the tongue to function properly against the roof of the mouth. So it'll give you your rest back at the roof as well as the function up to the roof. Basically, the guide doesn't let the tongue misbehave, but it also has the buccal flange that gets between the lips and cheeks. So it will push back on the lip and cheek activity that is usually added by compensating for the poor tongue function and musculature happening inside. We recruit the lips and cheeks to swallow. So the child who's out of balance grows poorly, and sure enough, we can regain that with these appliances. And so over the years, I've used these plenty. I'm going to share a few cases real quick, and then we're going to build our way to how kind of this evolved into what Toothpillow is. Children present with symptoms. So we have bedwetting and ear infections right here. The children might come in at age 5. Here's a 5-year-old, an example here, and he comes in and you can see the dry, cracked lips and that less than energetic facial look. The profile is telling. Of course, he's got the upper lip to the lower lip to the chin, and the chin is coming very far back. The lower jaw is so far back, the neck is kind of popping out. We have the bulge here. So all of this is, very bad for breathing, and a child like this would have at minimum sleep disorder breathing and probably be a poor breather during the day and worse at night. And then, of course, we could get involved with this early because we know already we have a lack of primary spacing as well as a deep bite. So according to Dr. Bogue, proper spacing for the primary teeth is that a nickel should fit between all of those anterior teeth. And a nickel is our thickest coin, and Dr. Bogue knew that if you wanted to have your dentition grow beautifully, you were going to have a nickel space between all the baby teeth. But you'd also have a nice distance between the upper molars early, and you'd have a view of the bottom teeth. The lower jaw wouldn't be trapped back. These are credentials here of that crowded deep bite class 2 malocclusion that don't self-correct. So these things, according to Dr. Bogue, when they were measured in the primary dentition, get progressively irregular. So those were the words he used. Malocclusions don't autocorrect or self-correct. They have no chance at improving, according to Dr. Bogue. So we know this child will only get worse over time. And why would we wait until 12 to work on the symptoms when we could work on the cause earlier? So we'll deliver an appliance for him to wear about an hour a day and overnight, and slowly time will go by. So basically we're watching the grass grow, but this is a change in probably a couple of years to go from 5 to 7, maybe, when the new teeth are coming in the front. So over the course of time, as that child is wearing their guide, the bedwetting will stop. And the bedwetting stops as soon as the sympathetic nervous system shuts off. So restoring the nasal breathing at night shuts off the sympathetic nervous system. That usually restores the bedwetting. If the sympathetic nervous system is active, we have sleep fragmentation. The bedwetters usually have sleep fragmented sleep cycles. So we want to get them out of their sleep fragmentation. And bedwetting is easy to control by shutting off the sympathetic nervous system, but you just have to have proper breathing. You don't need full jaw growth and development early on to have the bedwetting stop. You just need better breathing. So when the guidance appliance is in place at night, you have the nose doing the breathing. We do incorporate nasal hygiene, of course. So the nasal hygiene is going to get rolling so the child can use natural sprays, get the nose clean and clear, wear their guide to bed. And by wearing it an hour a day and overnight, you start retraining the nasal breathing. And once the nasal breathing is happening, you can then have that sympathetic reduction and basically a better sleep cycle, and the bedwetting can decrease. Over time, we might get to the age of 8 where the permanent teeth are coming in, and what was a crowded deep bite is now a class 1 normal overbite overjet relationship where the permanent teeth are coming in nice and straight. And sure enough, from the primary to the permanent dentition, this is almost full eruption of the permanent teeth, but every permanent tooth has a beautiful chamber. So we have a beautiful arch form at an appropriate arch width. And this child on the left side of the screen actually had some overlap or crowding of the baby teeth there at the incisors. So that child has, without intervention, no chance of the teeth coming in without crowding. And if they're going to come in with crowding, we may as well deliver something early that they can use to unravel those teeth. And basically the teeth unravel secondary to the jaws growing, and the jaws are growing because we're redelivering the basic muscle function we should have. The tongue proper and the lips and cheeks not involved. So we flip the script. You know, the child is in the condition they are because of the weak and dysfunctional tongue musculature. It's low lying. And in order to compensate to get swallowing happening, they'll recruit their face. And all of a sudden, when they're using their lips and cheeks, we have outside strong and hyperactive, inside weak. If we flip that to the inside, we'll go to the palate and function and rest appropriately. And the flange will push away on the lips and cheeks. We now get our kind of tongue activity appropriate inside and the outside removed. Now we can grow the other way, wider and forward. So the guides offer an opportunity for a child to get their growth back through their breathing and musculature. And as the jaws grow, the teeth go where they belong. So a opportunity early is that the guides can deliver the jaw growth and development, and then of course have the teeth go. And this is a child who hasn't had anything else. So there's no brackets or wires or aligners or expanders. This just happens to be the guidance appliance only, getting us all the way to where we might be 11 years old or 12 years old and have a beautiful class 1 bite with perfectly aligned teeth and not having had anything. There's no aligners, no brackets, no wires, no expanders. This is just a guidance appliance alone for an hour in the evening plus overnight. As the years go by, we do reduce it. We don't have to do the hour every day forever. The hour goes away. As you regain your breathing and musculature, the body will do it itself. So we actually wean off of the guides over time. What we get is a starting point, 1 hour a day plus overnight. And then as we have our breathing and musculature and we recognize, okay, here comes growth, here comes improvement, we start taking away the hour and let the body do it itself. As we're gaining more progress, what we do is we take away every night and make it every other night. So we'll go to 3 nights a week, then 2 nights a week, then 1 night a week. So a child who begins at 5, over a period of time, will lose the hour a day component of this, but then also we'll start losing the days and graduate down from 7 nights a week to 5 to 3 to 1. And by the time he's 12, he's only wearing it once a week for the previous year. So when you hit that last permanent tooth, you're only wearing it once a week, basically proving stability in that as you're only wearing this once a week, you get to the point where your breathing and your musculature is such that it guides the rest of this to land where it belongs. And we only use the guide once a week to be like a little bit of a support system along the way. Over the time, he'll get his forward growth. Now, here we are at about age 12, maybe, so the progress is very nice. He's not done growing. No child is done growing at 12, but we have a very nice improvement in the neck and the jawline. So what was really far back and bulging out in the neck is now tucking itself up as he grows forward. Since starting the guidance appliances within the first few months, he lost the bedwetting symptom and he's never had another ear infection. So from 5 till about 12, we have 7 years with no ear infections. A proper swallow with the nasal breathing usually results in, the decrease and or elimination of the symptoms. And two of the big ones are bedwetting and ear infections. So we no longer have that going on for him. He's in great shape. 4, so age 4, here's another one. Behavior and attention and all this focus and attention and behavior comes in quite a bit because kids who go to preschool or any school really, if they are hyperactive and running around, the parents will get a call and the parents will go to the pediatrician and one thing will lead to another and you can get a diagnosis. And we all know where this is headed, that ADHD category, and they do diagnose the children as young as 2 years old now. So the opportunity for a child to be diagnosed as young as 2 and offered medication does exist. And the age group of 2, 3, and 4 for medication was added 10 years ago. So it was 2014. 2014 was the year that 2, 3, and 4-year-olds were added to the ADHD diagnosis for medication routine. Prior to that, it was as low as age 5. It worked its way from teen to 10 to 7 to 5. 2, 3, and 4 were added a decade ago. If you didn't know that, it was a shock when I learned it, but that's a surprise. So here we go. Teeth grinding, that's very common. We see a lot of kids grinding their teeth. Thanks to Dr. Gerald Simmons, we learned that the grinding is usually an airway related issue. And with airflow and pressure issues from your compromised airway, your teeth are going to grind as a protective measure to move the lower jaw and the tongue around to help the air get by better. So it's a protective mechanism. So we're going to recognize that children grinding their teeth need early intervention, not wait and see, or they'll outgrow it, or it's normal. That's not helping the kids out. So when the little guy comes in, we recognize right away that he's got a profile that is deficient. And similarly, the lower jaw is very far back and the neck is popping out. So this child will be compensating in many ways. He'll have difficulty sleeping. He'll wake up at night. He will, have attention and behavioral issues during the day. And of course, that whole pathway gets started. But meanwhile, we get to meet him. Same thing, we're looking at a crowded malocclusion, crowded deep bite, and soon to be class 2 if it isn't already. And he might have one spot that a nickel would fit, maybe a naturally, and we already know where the lower jaw is kind of all the way trapped back. Progress. We're going to deliver a guidance appliance for him. He's going to use his appliance for 1 hour a day plus overnight to start. And from the time he gets from 4 till about 7 years old, we have a nice amount of progress in that redirecting the breathing and the musculature gives you back your jaw growth and development. And as we get our jaw growth and development back, we see the improvements in the teeth and the bite. The permanent teeth erupt without crowding, and the bite starts to slowly improve towards that class 1 normal overbite over jet we're looking for. But it's very nice in just the age from 4 to about 7.5 at this point, is that he has a beautiful amount of mid-face and lower face development. He has proportionate lips. They're sealed. He breathes through his nose. And this isn't the important photograph. This one is. So in just progress alone from the guide, he has his beautiful wider and forward growth. And of course, with the nasal breathing comes the sleep cycles restored, the sympathetic nervous system shut off. And of course, with proper sleep cycles, he doesn't have the behavioral issues during the day. So this is a child that can go back to school without medication and then, of course, function normally without having attention and or hyperactive or focus issues, where he will no longer be considered for medication. It's only progress too, because when you get to 7, you're not done. We're going to be reducing our guide use and letting the musculature take over. Most of the kids we treat can wean rather quickly as they have good compliance. The ones without the compliance will wear them a little bit longer for the hour and overnight because they might need more time to get caught up. But once you've got good compliance, he'll be down. At this age, he's probably only wearing it 3 nights a week by now, because when you get your breathing and musculature back, it will take over and run the show for you. So we are looking to wean off the appliances. Here's another fun one. Age 3 comes in. This patient gets to us with a few symptoms. We have maxillary mandibular deficiency here. You're going to see very severely underdeveloped jaws in that class 3 style bite already. Trouble falling asleep, waking at night, of course, sleep disorder, breathing. But at 3 years old comes in because already told at a different office that you have to prepare for jaw surgery when you're older. And this is why. When she is biting down at the ear, but you're going to see it in a second, this is a full class 3 bite. Midfacial deficiency, but really the class 3 doesn't mean the lower jaw is too big. It just means that the lower jaw might be ahead of the upper jaw, but not too far forward. So we take a look at our child here and we can see that, yep, mid-face deficiency, overclosed. We are hooked into that class 3 bite. And the lower jaw with the crease in the lip and the neck popping out is actually too far back. So just because we might have a class 3 bite coming, it doesn't mean the lower jaw is too far forward. So it just means the lower is ahead of the upper. both jaws are too far forward. So she's narrowing back, and we're going to have to go the opposite direction. But here's her bite at age 3. And you could see why someone might mention this is a possible jaw surgery in your future. But that office didn't offer any other solutions. And we have a different solution than jaw surgery in the future. In fact, that would probably be the number 1 thing to avoid is jaw surgery. And the number 2 thing to avoid would be extraction of teeth. You could put those 1, 2 in any order. I think the jaw surgeries probably are more horrific for teenagers and adults. So we try to avoid that at all costs. But those who know or have heard me speak before know we are definitely trying to avoid extractions on all children everywhere. And the ones who have come through our practice have had no extractions, and we're over 20 years without a single tooth extracted in all of the kids we've treated. That's consecutive without an extraction yet. So this child comes in like this, and we are looking at this type of bite. And I can assure you that that is the most retruded her lower jaw can be. So in having her, speak, eat little crackers, drink some water, play with the jaw, manipulate, because sometimes the kids do posture forward. I'm well aware about posturing forward, but this is her most retruded position. And then, of course, we're going to get involved with the guides. There is a very specific guidance appliance for the class 3 type of bite that we utilize, and it's a wonderful appliance, and we start early. Happy to meet at age 3 because that's where we begin. This is just 5 months later. Now, 5 months later, we have a big change in the face. So while the bite just shows a slight improvement in the mouth, about half of the overjet and overbite are corrected, we have a very big difference in the profile. And what you notice from the bite is that the lower jaw has gone forward a substantial amount. And so what you're seeing here, because of the class 3 effect, is that the upper jaw is growing at, let's say, 3x, but the lower jaw is growing at 2x. So the appliance is designed to deliver more growth to the upper than the lower. Both jaws get attention, but the way they direct the musculature gives the upper a little extra. So when the appliance is in place, we have our nasal breathing. That's a benefit to any child. But when this particular guide is in place for this child, the tongue gets more effect in the palate, as well as there's an opportunity for there to be no effect of the lower lip against that chin. So we're going to have all of this opportunity to have the upper outgrow the lower. So we are getting wider and forward growth, bigger maxilla, bigger mandible, wider and forward, and the distance the lower came forward, the upper is catching up to it. So we have upper growth 3 times, lower growth 2 times, and with that pace, we'll eventually get where we need to be. Now that her neck is coming forward like this, we can see that with all of that advancement leads to better breathing. The child will sleep through the night, wake up refreshed, and do very well. But this is just 12 months now. And at 12 months, we have a 4-year-old. So we've gone from 3 to 4. This is 3 to 4 years old. Now, it's wonderful progress because we're only here dealing with a myofunctional guidance appliance that when she wears it an hour a day, plus wears it to bed, again, redirecting the breathing, redirecting the musculature. Only good things can happen when you guide that tongue up and when you push away the lips and cheeks. So redirecting or flipping the script on the musculature is the action that's doing this. So the guides themselves, they're not expanders. There's no turning of them. You saw the picture earlier, you pop it in your mouth. So what it does is it delivers the body's natural growth and expander, which is the tongue. And the tongue is what's meant to grow the jaws. So why don't we just give it back to the child? And that's what these guides do. The guides give you back your natural ability to grow your jaws wider and forward through producing tongue activity that's appropriate, rest and activity that's appropriate, and pushing away the lips and cheeks that are basically hyperactive and compensating. So at 12 months, we look like this. So at 12 months, we are still kind of growing wider and forward. She's pursing her lips a little bit in the photo, but we just show them as they are. But you can see the length, the jaw length from her chin to her neck is very long now instead of short and ramped down. So the lower jaw is growing. The width is giving her a jawline now. Her cheeks and her jawline are wider than her neck. So now we have this beautiful wide and forward growth. And here you can see a difference in the size of the maxilla and mandible by width. And we already obviously saw forward. She starts getting full lip form. So now instead of having these straight line lips that are folded back because everything's too far back, we have a child who is now growing wider and forward. And again, this is only age 4. We went from 3 to 4 years old. And from 3 to 4 years old, this child wears that guidance appliance 1 hour a day plus overnight. And gradually, when we get those teeth to edge and over, we'll reduce, we'll take away the hour. And then we'll go from every night to 5 nights a week, 3 nights a week, 2 nights a week, 1 night a week, and she'll do that. And then, of course, eventually she'll become a teenager that can have clear aligners. And that's exactly what she's doing now. This child is actually now 15 years old and doing a few aligners because Her permanent teeth came in really close to where they belong. She's never had expanders, never had brackets, never had wires, never had any 15 doing a dozen aligners just for a little final alignment. And that's a nice thing to get as an end result of starting with that type of bite. So there are some nice research articles out there to kind of show how bad sleeping can be for kids. And so the sleeping and breathing changes can be. So here we have this nice little article here, effect of sleep changes on health-related quality of life in healthy kids. So here we have this article, effect of sleep changes. And the fascinating thing is that it only took 39 minutes to kind of, make a child unhealthy. In this secondary analysis of the DREAM randomized crossover trial of sleep manipulation, we showed that after only 1 week of receiving 39 minutes less sleep per night between sleep conditions, children reported significantly lower health-related quality of life in terms of their physical and overall well-being and ability to cope well at school. These findings highlight that ensuring children receive sufficient good quality sleep is an important child health issue. Now, the last sentence is very important because it says ensuring children receive sufficient good quality of sleep. It's not exactly about the quantity of sleep, it's about the quality. So we'll look at the two things. Quantity. Yeah, a child should have their 8, 10, 11, whatever the hours are for their age group. So according to our age, we would know what is the quantity of sleep. But that's one box to check off. Did they get the right amount of time asleep? Number 2 would be the quality. Where does the quality of sleep come from? Well, you can talk about sleep hygiene and think about, well, the dark room, quiet room, cooler versus warmer. There's little boxes you can check there, but mostly the quality of sleep is related to the breathing. And when you are breathing through your mouth or worse, anything from nasal airflow resistance or worse will disrupt your sleep cycle. So you will have sleep fragmentation. Sleep fragmentation interferes with, and you will be more likely to miss that 39 minutes from having sleep fragmentation from poor breathing than actually being woken up in a study like this. So any child that has nasal airflow resistance or mouth breathing or all the way to OSA is going to lose that 39 minutes in 1 week's time. That child will have a significant difference in their future going forward. And look at that, 1 week, 39 minutes less. The kids we're meeting have way more than this going on. And sadly, we can't provide enough quantity of sleep to overcome the quality. So there's no amount of sleep that can overcome poor sleep, and the quality from their underdeveloped jaws and breathing issues is rather evident. Then there's another fascinating one here in the QR codes there. You should all read this one. Effectiveness of functional orthopedic appliances as an alternative treatment among children and adolescents with obstructive sleep apnea. Systematic review and meta-analysis. This is a 15-page paper, and they reviewed a whole bunch of different styles of appliances. And part of the review included the ones, similar appliances to what you saw, where they were the passive, called monoblock. They use monoblock because your just teeth close into it, kind of a thing. So similar style removable myofunctional appliances are found in this research, all showing improvements. Functional jaw orthopedic appliances are appropriate and effective for children or adolescents whose OSA whose etiology is deficient maxillomandibular growth and development. Functional jaw orthopedics treats the form and function of the stomatognathous system, thereby enhancing quality of life. So it's nice that this article pulled together all the data that's out there and put it all for you to read, so you could see that, yeah, appliances that are monoblock style, passive appliances that a child can wear, can improve AHI and OSA scores across the board. So they notice and put in the research for you an opportunity to see that these appliances do provide, do address the form and function of the system. And of course, we know that anything that's used that retracts, if it keeps you narrow, makes you narrow, or retracts you, you'll have a worsening of symptoms and or add symptoms to a child. Whereas if you go the other way, if you're going wider and forward, you have the opportunity to reduce or eliminate symptoms. And the functional jaw orthopedic appliances that are generally called, which the myofunctional guidance appliances are included in this group, have the opportunity to deliver the musculature and the breathing. And so anytime you redirect the breathing and the musculature, you get your growth of your jaws back. So again, the appliances are not expanders, and they don't have any mechanism of action other than redirecting your own natural musculature to behave properly. So in that manner, you can only have something positive happen to these children. And we think about, what are the pros? So the pros, they're impressionless and scanless. We don't have to take impressions or scan. Again, I mentioned that there are over 18 different shapes and sizes and styles based on the dentition, whether we have primary, mixed, or permanent. And then in each category, there are multiple to choose from based on the type of malocclusion we might be looking at. They are breathing and musculature based, and so they're not tooth focused. They are breathing and musculature based. It's not about the teeth at these ages. It's about the foundation. And the foundation is compromised thanks to the soft tissue dysfunction. So we'd like to regain that. These are team friendly in an office. They're comfortable. It's non-invasive. They're harmless. There's no risk. There's almost no contraindication. The only instance where we don't deliver these to children is if there's some sort of a syndrome that might prevent them from using them well, or having a history of maybe cleft lip and palate surgeries. The two categories that we have used them rarely would be the Down syndrome children, some of the Asperger's, autistic, and spectrum children have difficulty, so we haven't used much there. And then cleft lip and palate, haven't had much opportunity there either. The opportunity to treat the cause instead of the symptoms forever. We all know what Braces Late offers. Braces at age 12 treats the symptoms only. So braces give you straight teeth temporarily. That's not an opportunity that has anything stable built into it. And then the most fascinating thing about the myofunctional guidance opportunity is that it can be done remotely. And can be done remotely is what kind of leads us into our next topic of how kind of we got to Toothpillow. We're going to get to that in a minute. Some of the cons are really just the compliance. The only negative thing that can happen is if you didn't wear it. If you don't wear it, you don't improve. A guidance appliance in the mouth can only help you with nose breathing and can only have your tongue appropriate and lips and cheeks pushed away. So you can only help the musculature with your guide, meaning you can only make an improvement, and it really is based on compliance. A child who wears it well does beautifully. And then, of course, when we think about the pros for the patients, well, again, impressionless or scanless, it's breathing and musculature based, so it is in the cause, treat the cause category. They're comfortable, non-invasive, they're user-friendly, it's harmless, there's no risk. You can avoid more invasive techniques, of course. In my own practice, where we are now over 2 decades of using these, I can tell you that in the age group from 3 to 7, the kids who wear their guides well avoid expanders altogether. We do a fair amount of expanders between 8 and 12. When we do expanders from 8 to 12, when we remove them, we give them the guide. So we go from the expanders to the guides in the 8 to 12 category for some kids. But if you're 3 to 7 and you get a guide and wear it well, you're not getting expanders. And if you do need expanders between 8 and 12, you can have an expander first and a guide second to get your breathing and musculature back. And then, of course, the 8 to 12-year-olds who don't need expanders first, but still don't have well-aligned teeth with fully grown jaws can have the guides. In my own practice, it runs about 75% of 8 to 12-year-olds can use guides directly, whereas about 25% of 8 to 12-year-olds do need to have expanders first. And this has kind of proved its way into Toothpillow, which we'll review in a minute as we get to that. Avoiding more invasive techniques. And certainly if you could avoid expanders, wonderful. Start earlier and avoid them altogether. If you can avoid extractions, you just need to start earlier, get your jaw growth. If we can have the foundation size right, we don't need extractions. And then, of course, we get to avoid jaw surgeries as a teen or an adult, which it would be nice if no child had to have a jaw surgery when they were a teenager or an adult, if they could just get the breathing musculature correct early, have their jaw growth and development, have the first 28 teeth come into place beautifully. Then we get to see and track over time with over 2 decades, how do the wisdom teeth land? And it turns out that now we only send about 1 out of 4 kids to get their wisdom teeth out, provided we started between 3 and 7. So starting between 3 and 7 and getting the jaw growth early, we notice that most of the wisdom teeth we have coming will erupt into function without any discomfort and need no assistance. The 1 out of 4 comes from the kids coming late. If you're 8 and above, it's a little bit late. We might get the right size, but the wisdom teeth are already forming and rotating, and I can't recover that. So we do have a 1 in 4 wisdom tooth referral rate now, which is, it's still disappointing. We'd love it to be 0, but I can't seem to get to 0 because I can't meet every child before the age of 8. An opportunity to treat the cause early instead of the symptoms forever. It's cost effective. Guidance appliances are inexpensive compared to other techniques. The cons for the parents or patients are still be compliance. Obviously the one drawback is that we might not have the best compliance and we don't get everything out of it. So it's, it's like a gym membership. If you go all the time, you get the results. If you don't go all the time, you don't get the results. And so it's that simple. You really can't hurt yourself, with a guidance appliance. But it brings us to Toothpillow. And so I've been involved using guidance appliances in my office. And what we started out with in the beginning was a bit of a lack of knowledge. And so when I began this a little over 20 years ago, I did not know about the myofunctional therapy community. And then one of the first ones I ever met was Paula Fabi. and Paula Fabi, followed by Joy Moeller. And then I met Sandy Coulson. And one after the next, I started meeting them. And of course, locally, Brittany Sierra Murphy is over here. And, I managed to meet Dana Hockenberry, and that list goes on and on and on. But embarrassed to say that 20 something years ago, I didn't know of this community, and I was using guidance appliances without their support. But now, fast forward into this, I recognize that, well, we need the myofunctional therapist involved as well, because the collaborative care makes a better result for the child, and it can even be sooner. So we get involved with the myofunctional therapy community. On top of that, we start to look for maybe frenum and tightness in the lip, cheek, or tongue, because releasing those also helps a child with their growth and development. So when you're thinking about nasal hygiene products and techniques and support, that's a part of Toothpillow. Toothpillow is basically 3 things wrapped up, delivered remotely. So nasal hygiene products that are natural, techniques to get your nose clean and keep it clean, and support on a daily, weekly, monthly basis to make sure that's happening is one of the foundational pieces of Toothpillow. The myofunctional guidance appliances are also a foundational piece of Toothpillow. And again, with 18 or more different shapes and sizes and styles, depending upon the dentition you have, we have the opportunity to treat most children. And we can incorporate myofunctional therapy remotely via Zoom. And so we do connect, we have an app as well, but we do connect via Zoom to get the child sessions with the myofunctional therapist. Combining the guides with myofunctional therapy and nasal hygiene makes for a wonderful opportunity for kids of all ages. And in my office, as these things started to be added, we could recognize that the results got even better and better. Fast forward to a few years ago, and a gentleman that you're going to meet shortly is Chad Rasmussen. He approaches me and says, you've been doing this in your office quite a while, and so has Dr. Hale and Dr. Goals, and we have Michelle over here and I are talking, and they came up with the bright idea that, is there a way to do this remotely? And it seemed like, a smart idea. I had already been treating the kids so long and in a manner where we were just checking them every 6 months in the hygiene chair. So I know you can let 6 months go by wearing your guide and come in and look better when you get back. So we have this 6-month interval. Then, of course, we have kids who come in from out of town to get this. So you're treating a family locally, and there's no provider of these near the family members, like a sibling. And so they say, well, you're coming in for the holiday. Can we just go into Dr. Ben's office and get our guides and do our, So sure, of course you can. So they come visit the family, and we get them, get their guides in there, and they take them home. They come every year. So we were already seeing kids once a year on holiday time to check their guides. And if they needed a new one, we mail it. So basically this whole remote thing was put together from the bright idea of Chad Rasmussen and Michelle Grasmick. And with myself and Callie Hale, Dr. Goals, we have Lauren in there as well. Our founding team built out this over the last 3 years, where we put together a pathway to deliver this remotely. So Toothpillow is a company, and it is a company name, but it does do 3 things. And it guides the nasal hygiene, it guides the appliance delivery and use, and we have myofunctional therapy incorporated. All of this is delivered and monitored remotely to solve for access. So any parent anywhere could find us, learn about us, and decide this is a good choice for their child and be able to deliver this to them. We have a support team that is, I think, over 40 members right now, and they engage the parents daily, weekly, monthly, and quarterly. So we are all over these parents through the app, and our support team is beautiful people who have used this in their families and know the benefits of it for their children. And they, engage the parents on a daily, weekly, monthly, and quarterly basis. But on top of that, we also have licensed dentists helping us, which we have licensed dentists in every state. So we have all 50 states covered. We now have over 70 dentists who participate, and they are responsible for monitoring the treatment. And quarterly is the largest gap. But meanwhile, if there was a clinical question that comes up, the dentist gets pinged and they jump in to help answer a question from mom. So we have a pathway to have both basically doctor and team member involved in this, just like it would be in the office. So the Toothpillow model was built out based off of an in-office technique that could be done remotely, and on some regard was done remotely. And it basically solves for access and affordability. And one other problem it solved for was that very few dental offices, whether they're dental office GP, pediatric dentist, or orthodontist, very few offices really picked up this early opportunity for kids to do in their office. And so it's nice that if you, let's say, want to remain focused on the teeth and not necessarily engage in this, you can refer children to it. You don't have to, be a provider of it in your practice. While that's an option, you can also just go ahead and refer them to Toothpillow. And that basically is an opportunity for me to kind of turn it over to Chad to build out a little more about what Toothpillow is and all about. And you got a piece of the clinical aspect of what's being done behind the scenes.
Before we do that, such a smooth transition. Thank you. But I'm gonna just, sorry, Chad, I know you're like, I'm chomping at the bit. But Ben, while we have, I'm gonna go back to your screen, if you would. There are just a couple of questions on the cases, and I didn't want to get it lost in translation before we moved on to the Toothpillow forum.
Sure.
Was there any myotherapy in the first case or any of the cases that you showed? And if not, why?
Yeah, so I purposely showed older cases that did not have myofunctional therapy, and I prefaced it in my speech with there was a time where I was ignorant to it and I didn't know. When I first learned about the guidance appliances over 2 decades ago, I didn't know about the myofunctional therapy community, and so I was basically doing this the hard way, in that letting the guide do all the work and making sure the nasal hygiene and the guide and all that going on. We still had nice results. But it's like anything else, the more you learn, the more you do better. And so I wanted to do better for the patients. And sure enough, I believe Paula Fabi was the first person I met in the myofunctional therapy community. And as soon as I met her, I knew that this had to be done. And now I do refer the kids and the adults to myofunctional therapy. So we have a transition over time. It's an evolution. I wish I knew about it from day one. I've been in practice 31 years. I wish I knew about the guides 31 years ago. I wish I knew about myofunctional 31 years ago. I wish I came out of school doing this. You know, the regret is not knowing it earlier. So I wasn't showing the cases to make any other point other than when I first started, I was ignorant. I didn't know the myofunctional therapy existed, but meanwhile, there was success with the guides only. And now we only do it with myofunctional therapy. So with Toothpillow is built out to include the guides, the myofunctional therapist, and also the nasal hygiene. Those are 3 things that remotely can change a child's growth and development.
Thank you for clarifying. Was there a tongue tie in any of the 3 cases?
So similar here, while they may have had it at the very start of this 20 years ago or 22, whatever it is now, I didn't know to even assess the frenum. And so my first years into the guidance appliances, I did not do frenum assessments or revisions on any of the kids. So the 3 kids you looked at today did not have frenum assessments or frenum revisions.
Okay. I just think if there's any questions on the cases itself, and then we'll move on and we'll go
And the
back
good
to
news
the
is through
questions.
Toothpillow, while
Yes.
we have the photographic, analysis of the pictures, right, for the kids, we also have the myofunctional therapy via Zoom with the children. Now we start to recognize through that we can screen for frenum tightness, and we make referrals. So we don't ignore the frenum at Toothpillow. We're looking for it, because most kids are either told if you go to the pediatrician, you're likely to be told, oh, that's not a thing. It's not tight. Don't worry. They don't have a tongue tie. So we make sure that we get an assessment enough that we can give some guidance to a parent to say, there may be a tightness in the lip, cheek, or tongue, and that could be released and help your child. So we do a lot of investigating their area to try to give them a good referral locally, where they could get a frenum inspection, diagnosis, and release. And then, of course, with the myofunctional therapy, we always do that with myofunctional therapy first, frenum release second when indicated, then continuing the therapy. So we do take it on seriously with the Toothpillow screenings, that children who have tight frenum, it is a large percentage have it. We want to make sure we guide them in their communities to get a beautiful revision done somewhere.
Perfect. And then about the first case, the 5-year-old, the appliances, is it a one size fits all, or they're preformed in various sizes, almost like selecting stainless steel crowns, or they're customized with taking an impression? Did you make multiple guides as he grew bigger? And that answers
Right.
a lot of these questions, actually.
Yeah. So no, it's impressionless and scanless. It's not about the teeth. And so the guides are about the breathing and musculature. So the guides do come in different sizes, shapes, and styles based on the dentition. So in primary dentition, there are several different styles, shapes, and sizes based on the type of bite you have, whether it's class 1, 2, or 3. In mixed dentition, similarly, there are different shapes and styles and sizes that are based on the type of bite that you might have. And then in permanent too. So they're not a one size fits all. In total, when I was counting them up, there's 18 or more. So there's 18 or more different shapes, sizes, and styles of these appliances that go from primary to mixed to permanent. But they're not about the teeth. They're about the breathing and musculature. So when you pop it in your mouth, you get your breathing right, you get your muscles right. The later stages, when you're advancing through, there are several to go through along the way. The later stages do have attention to the teeth, where we actually have sizes for the teeth, and we have a proprietary ruler that goes to the parents, and they take a picture against the teeth, and then we have a way to scale that to send them the proper size. So that's more of the finishing technique, where you have the jaw size and growing beautifully. Then you do want to attend to the teeth. So what begins as a breathing and musculature pathway, as the jaws are growing and the teeth are spreading out nicely and taking position, we would like to finish the job. So the later stage guides do get measured by a ruler that is done remotely, and then we can send the proper one to then finish the job with the tooth alignment. And of course, perfect bite coordination. So we do have, towards the end stages, more sizes there. And that's why in the grand scheme of things, there's over 18 different appliances to use, but we don't use all 18 in a child. You know, if I had to guess, probably an average would be about 3 to 4. It takes about 3 to 4 appliances to treat a child through. And that's, you know, hopefully enough of an answer for that big question.
Yeah, that's a great question. Thank you for that answer. And I'm trying to do a smooth transition, like Ben had you all teed up. And I'm like, wait, stop the press. So Chad, why don't you come off mute and welcome. We're so thrilled to have you. I know you can help with a lot of these questions about Toothpillow, but let's start with the why. Like, this was your vision, you and Michelle, but really this is kind of your baby as being CEO. Tell us a little bit about the mission of Toothpillow, and then share with us more of the workflow and the platform and how providers can get involved.
Thanks, Lauren. And thanks for organizing this event tonight. Thanks to all the, hundreds of people that are here with us tonight and taking time out of your nights away from your family to learn more about this. It's incredibly humbling for us to be able to share this with you. My story started about 5 years ago, learning from Dr. Ben. I'd gotten involved with a company that was on a mission to change this. I was in an entirely different industry before. I was in home security, smart home, solar energy, totally different, not looking to change necessarily. And this company reached out to me to ask if I can help with their sales and marketing. That company happened to be one called Vivos that many people have heard of. I used to be a part of that company. And that was my, entrance into this space. And my day one of going into training to learn about this, I didn't know, what any of the teeth names were, how many teeth we were supposed to have, or any of this. I was not dentally trained, but I remember it was incredibly impactful because they played a clip of Dr. Ben. Dr. Ben was talking about how our jaw development impacts our ability to breathe well, which can impact our sleep, which can impact our health. And that was the first time I had ever heard that. And I was 40 some odd years old at the time. And the fact that that was not an obvious, it sounded obvious when I heard that, but then but I had never heard that before. And then I started looking inside my own family. So not that this is about me, but I want to get to know those people that are with us tonight. And if I can just share with you my own personal story as to why we're wanting to do this, I think my family story is just a common one. Families all throughout America, all throughout the world are this way. And so I'll just show you some family photos here and tell you a little family story along the way. So this is my family here. My amazing wife, Teresa, she goes by T. She had 3 amazing kids before we were married. We've been married 18 years. And then we added a set of twins ourselves, Jaylee and Jacoby. And at that time, 5 years ago, Jaylee and Jacoby were going into the 2nd grade. And their teacher had, shortly after hearing Dr. Ben's training, their teacher came and stopped my wife in the carpool lane and said this about my innocent little Jacoby. Look at this guy. Look at this little dude right here. And this is what the teacher said: "Your son is distracting and disrespectful." And that was it. This disrespectful when my wife heard that, she's like, "Oh no, not little Jacoby. We better do something about this." Well, what we learned tonight, again, this kind of cascading series of events, small jaws, small airway, small breathing, and so on. We took our little guy, Jacoby, to a dentist. And this is what the dentist, and all you hundreds of dental professionals on tonight, if you just look at his photo, you're going to pop up all these things. And what you're going to see immediately from a dental perspective are crossbites, crowding, gum recession, inflamed gums, early extraction, dental caries, narrow arches, chapped lips. But as we now know, we need to look beyond that. Well, is there something else going on? Now, fortunately, the American Dental Association had said that a dentist's recognition of suboptimal growth and development should lead to early intervention. So going back, this is suboptimally growing right here. So how can we intervene? And furthermore, in a child undiagnosed or untreated OSA can lead to all these other health issues. So was this happening in my own son's mouth? Was there a small jaw? Did it potentially lead to a compromised airway, sleep disordered breathing? And then were there other things like anxiety, depression, ADHD, hyperactivity, all those things? That's what the teacher was complaining about, his distracting, his disrespecting, those things. And so we wanted to kind of, once again, look under the hood. This was his mouth. We went further and we saw we had him do a home sleep test, and that's not part of Toothpillow's protocol to necessarily do this, because we can just treat on suboptimal growth. But this is what we did with my son. And this arrow is pointing to this number right here, 7.6 apneas and hypopneas. That's how many essentially times he stopped breathing per hour, which was essentially once every 10 minutes. My son was, for lack of a better term, suffocating every night, every 10 minutes, not being able to sleep well, not being able to get that restoration that he needs. His body was constantly in fight or flight. And so that was holding him back. My little guy wasn't able to achieve his best self because his jaws were underdeveloped. And as we know, the reason for his jaws were underdeveloped because he had oral dysfunction. He was not myofunctionally ideal, and we needed to help that. So we got him into treatment. And this was Jacoby's treatment plan. It was guidance appliance for 1 to 2 hours a day, myofunctional therapy daily, nasal hygiene with the clear nasal spray, and guidance appliance at night. I'll be totally honest with you. The only thing that Jacoby did well was number 4, was wearing his guidance appliance at night. That's not like, as we know, we need to correct the oral dysfunction, and this will help this. But in my son's case, this was the only thing that he did well. And this was an example of the appliance. This one happens to be the Vivos starter appliance. This is what Jacoby's mouth went from in a period of about 10 months. Crowded, crooked, all these things, to now his teeth were aligning more straight. It started getting on that better path. Now, this was after about 10 months. He's not done. This is not a perfect orthodontic case. We're helping reduce the complexities of the orthodontic treatment. And in fact, he just started. This is now several years old. He just started clear aligner therapy, but it went from a very complex case to a much easier, kind of mild or moderate case now. But the better photo that I like is the one that we took just 3 months after he started treatment. And that's this one. The same teacher that was complaining about him being disrespectful and distracting reached out to my wife and said, "Can you and your husband come to school tomorrow? Your son's getting recognized at an assembly as the student of the month." And that's when I realized that, oh my gosh, Jacoby's just one normal kid that happened to have a small jaw, small airway, poor breathing, bad sleep. And it identified him as one thing. And as we corrected that, it completely changed. And how common is that story? We know that like 90+% of kids have underdeveloped jaws. Almost everybody has poor oral function. And so that's when I was like, we've got to do something better. Like the amount of myofunctional therapists that are out there, or the amount of dentists that are out there that know how to treat this, are so few compared to the total. We needed to go and find a way that we could help the 1 billion people that are estimated to suffer from this stuff. And this is why we started Toothpillow. Toothpillow is simply making airway treatment more accessible. We do that by providing screening, remote screening, personalized treatment, and virtual support. Our process is quite simple. Somebody fills out an online assessment. They will get an evaluation completed by an airway dentist, one of the 70 that work with us. Then they have a customized treatment plan that goes to them. What does the customized treatment plan include? It includes an airway dentist, which, like I said, we have 72 airway dentists that currently work with us. They should all have a myofunctional therapist. Right now, we only have 5. We need many more myofunctional therapists to be able to help the patients. And so a myofunctional therapist is part of the care team, as well as our virtual support team, AKA a virtual dental assistant. So They'll go through, they'll do this as online assessment, the virtual care, and then the customized treatment plan. And our cost of treatment is our recommended plan is $145 a month. That includes the guidance therapy, either MyoBrace or Vivos or whatever the dentist picks that's going to be best. And just so you guys know, they pick the Vivos guides probably about 95% of the time. It's a very good system. Now, Toothpillow is not the maker of any appliance. We use the best in-market appliances. Think of Toothpillow more as the name of our dental office. We are a DSO. That's the name of our virtual dental practice. And this is our recommended treatment plan, which includes the guidance therapy, as well as 10 sessions with a trained myofunctional therapist. And then obviously our ongoing support for throughout the 24 months. So we started out about 2 years ago. We started very slowly treating about 30 patients a month. We got about 500 patients in treatment, and we were confident that we were delivering high quality care with good outcomes and satisfied patients. And then it just kind of started happening. Families telling families of their results. And now just last month alone in September, we had over 1,800 new families and new patients came in and got screened through our virtual clinic. And I still like to say we're just getting started. This is going to continue to grow. We know that. We know the passion of these moms that are out there telling other moms. Some of them happen to be big influencers that are telling their audiences, and they will be coming in. And so we're forecasting, and our goal for next year is 100,000 new patient screenings. And we cannot do this alone. Toothpillow is just simply a platform to help patients find highly trained providers and get access to care that they need. And so for all of you on with us tonight, dentists or myofunctional therapists, we want you to join our team as either a screening provider. If you're just a dentist that is so busy and there's other aspects of dentistry that you love doing, that's great, because that's all important as well. But you might be able to identify patients that might have suboptimal growth or an airway issue, and you can join our network as a screening provider. You might be really passionate about this and say, hey, I would love to help any way I can. And you can also be a virtual treating provider, virtually seeing some of our patients. Now, Dr. Ben pointed out that not all patients are appropriate to be treated virtually. And so we are referring in about 20% of the patients into practices to get in-office treatment because they either want it or they need it in office. These same things go for myofunctional therapists. You can be a myofunctional therapist and know that, gosh, my patients might need this oral appliance therapy, and I don't know of an airway dentist in my area. I want to just be a screening provider and refer them over. They will continue to be under your myofunctional therapy care, and then just getting the oral appliance care through one of the dentists. Or again, you can join our virtual team, or some of those patients, as we know, doing this virtual stuff just isn't going to work for them. You need to see those patients. You need to see how that function is and correct the dysfunction, make sure the technique is right. And so many of our patients would love to go and see a myofunctional therapist in office or in person. So again, our invite to everybody on tonight is join our team as either a screening provider, virtual provider, and in-office provider. And then there's other ways and degrees of all those. We have things that are called hybrid providers, where you're going to be doing some of the screening, we'll do some of the virtual consulting, and then you'll still be doing the treating. Or a prime office where they're just like, you know what, I'm doing really good at this in my practice. I just want to utilize your app so it's a little bit better connected with my patients, and we're providing a higher level of support. Again, we just stand here to help patients get the access to care that they want, connecting patients with providers, and doing that what I think in a very effective way right now. And so, like I said, we just want you to please join our team, and we can go out and change the world. And so it's an honor for us to be on here tonight with you, to be able to share a little bit about this, share our story, so that we can go and help the millions of Jacobys out there. And again, we can't do this without amazing providers. So that's a bit about what Toothpillow does.
Well, it's amazing. I love the story because I love the motivation that comes behind it. I just want to get this screen up so people can screenshot and how to get involved. Let me just get it from this slide. It's not doing that. Okay, hold on. I'll get that up in a minute. But Yeah, let's take some questions, and I'm going to try to just get that slide up with the QR code. There we go. There's the next step to get involved. Okay, so you can take the QR code, we can get your information, and then you can have a one-on-one consultation. We have Erin and Ashley and Devin, and they're here to help you depending on what type of provider you are, and they will get you the help you need and answer all your questions one-on-one. So just please fill out the form so they can get in touch with you, and we can take it from there. But we do have lots of questions, so let's go ahead and just shoot from the hip. Dr. Boyd and Dr. Christensen, you want to come on camera and join us, and then we'll bring Dr. Cassie Klein, who's actually a pillow provider, and we also have Laura Eckhart, who is our director of Mayo, along with Brittany, who is not with us because she was going to try to be with us, but the girls are screaming. She has new twins, so I know she's not listening to us, but we totally understand. And we're bringing Laura Eckhart here too.
We had twins, my wife and I, so I know that your first year, I mean, it's hard with a newborn anytime, but when you got two of them, it's like you don't even know what's happening the entire first year. So,
okay, how do you share? Let's share. How do we evaluate the patient's compliance with Toothpillow? How is the compliance evaluated?
Yeah, I'll start out, and then Dr. Ben, maybe you could elaborate. So with the companion app, and maybe I can show it a little bit. So every patient has an app, and in here, they're assigned daily, weekly, monthly, and quarterly activities that they need to do. So the first 10 days, when a patient's starting treatment, they will click on the app, and every day it will guide them through the 5 things that they need to do. There's a little video that goes along with exactly how they do that. Once they start establishing their routine, then on a weekly basis, they're going to come in and they will report into us their compliance. How many days did they do their myofunctional exercises? How many days did they wear their appliance during the day for 1 to 2 hours? How many days did they wear it to bed? Et cetera. So we're asking all that. They report that in on their weekly check-in, and we get a compliance score of that patient. If their score starts going down, our care team starts, more proactively reaching out, finding out how else we can support them. And then on a monthly basis, they're taking a photo, and on a quarterly basis, every 90 days, they're submitting in all of their symptoms, a full set of photos, so that the doctors and the myofunctional therapists can really track their progression with this. So it's highly interactive in the app, and it's a great companion to guide these patients throughout their 24 months of care.
Wonderful. Ben? Mm-hmm.
Yeah, and right now we're using In-Hand Health, but we are currently building our portal where, if you're in the clear aligner world, how you have your portal with your cases. We're building that out. So a treating provider for a state will have a portal with all their patients in there, and it'll have their accumulating records along the way. So we'll have the sleep breathing questionnaire as it gets updated every quarter, as well as all the photos that get updated. And then, of course, there'll be comparisons built in there to give you an idea if we're going like better, green light, or worse, red light. And then we have ways to engage the patient through the support team and the doctor. So that's near completion, I think. We're getting close on that.
And if we're seeing that this pathway is not an effective treatment for this child, if they're not having success with it, we can always switch paths. That has happened several times with patients in treatment. They're just not getting the outcomes that we would hope. And then we change the treatment plan, refer them into office, and do a different, in many cases, maybe it's a fix expander that they might need at that point.
As a myofunctional therapist, I would love to recommend Toothpillow, but it sounds like you have your own myofunctional therapist. Will you talk about how we can all work together, or if we refer you for the guides, are you going to be recommending your own therapists? Chad, you want to take that, and Laura follow up on that?
Yeah.
Sure.
So if they are already under, just like with the dentist, if they're already under an orthodontic treatment, we will not move forward with prescribing orthodontic treatment if they're in an active treatment plan with another provider. Same thing goes if they're in an active treatment plan, or they came as a referral from a myofunctional therapist, then we will not kind of market to them our myofunctional therapy community, because they're already in good quality care with you. So then they can select a treatment plan that is one of our light plans that is just the oral appliance therapy, and they stay with you for their myofunctional therapy. We do not need to, if they're where they need to be, they're with you already, so they will just stay with you, and then they can just get the oral appliance therapy from the dentist. Laura.
Yes.
And by the way, you guys, this is, let me give her a little, we're
Please.
great. We're so thankful to work with Laura Eckhart. She's our director of myofunctional therapy, co-director alongside Brittany Murphy. And Laura Eckhart has been a myofunctional therapist for over 15 years. She worked hand in hand with Sandra Colson in her physical clinic in Denver, Colorado. Laura Eckhart has her own private clinic still that she treats patients, and she also works with Toothpillow. So she is a seasoned, highly trained myofunctional therapist, and we're grateful to have her on our team.
Thank you. Thank you.
Take it away.
I'm so happy to be part of it. So as Chad was just saying, if a little kiddo is already in treatment with you with myofunctional therapy, yay, we're so happy. We just want to provide the guidance appliance as well. And also we get a lot of kids who really need in-person treatment. So we want to refer them to you, and especially those younger children. And if they have access to you, that's great. We do have a lot of that live in remote areas and no one within, 2 hours driving distance. So that's where our virtual care is really nice, but we really, really love the gold standard of in-person care. So that's where we want the unity with all of you myofunctional therapists, that you can refer to us and we can refer to you. So it's really in best interest of all these children.
Thank you. Someone says, I've heard the appliances are retractive on the maxilla. Do the appliances address the anterior posterior dimensions of the oropharyngeal space through sagittal expansion? In other words, can it move the maxilla forward like with reverse headgear or orthotropics? Ben, you want to touch upon that? And then
Definitely.
Kevin and Bret, you can chime in too.
Sure. Yeah. So the more appropriate wording would be growth. And so because the tongue is the body's natural expander, and we say expander loosely because when the tongue is working properly, you get jaw growth and development. So when the tongue is working properly, you'll get your best maxillary and mandibular jaw growth and development, and you will have wider and forward. Good jaw growth and development is wider and forward, and underdeveloped is narrow and back. So the appliance, and I think I was pretty clear during the presentation that the appliance is not an expander. It doesn't have a turning mechanism. It has no mechanism of action on the jaws. What it does is it redirects the breathing and musculature. And how a child would normally naturally get their jaw growth and development would be through proper tongue rest and function, and then a lack of extra oral lip and cheek muscle activity. So if we had the early hard diet, like that pre-industrial, the pre-industrial pre-Western culture has that breastfeeding followed by early hard food, you have stronger and bigger musculature, proper tongue function and swallowing grows the jaws, and we don't see malocclusion in the pre-industrial Western communities. But once we get to the industrial Western societies where the early soft food picks up, the weaker, smaller muscles give us the underdeveloped jaws. So the appliance is not directing growth, directing an expansion or a sagittal movement. What it's doing is giving you back your tongue, and then, of course, taking away the lips and cheeks. So things like orthotropics that might give you wider and forward appliances that are turned and or used to move things are not necessarily using the musculature. They are directing forces on the bone to get your growth, whereas we are just giving you appliances that redirect your breathing and musculature to do the work for you. So the most natural way to do this is to get back your breathing and your musculature. And so in the myofunctional therapy community, that's kind of where everything works beautifully there, in that you're getting back to proper muscle function, meaning tongue rest posture is in the palate, the tongue functioning properly at appropriate strength, and then, of course, taking away that lip and cheek activity. And I know there's a whole lot more than that. I'm simplifying it. But this is not unlike that. These appliances give you back your proper breathing and musculature so you can have your jaw growth and development back. So the appliances are not retractive because by definition, they're only providing proper breathing and musculature. So to say a guidance appliance is retractive probably comes from a place of absolutely no research or resource to support it. And maybe someone might have an opinion based on seeing 1 or 2 kids having used the guide that didn't go well. But meanwhile, I think learning the whole history there would be appropriate because there probably was a missing piece. Wrong size, wasn't worn well. I could give 12 reasons why it might not have gone well, but that doesn't necessarily add up to the guides are retractive. So as far as the retractive story goes, the guidance appliances couldn't possibly deliver any type of a retractive move because they only give you back your proper tongue rest and function and take away lip and cheek activity. So you flip the script on the musculature, and therefore you could only grow wider and forward. So yes, you do get wider and forward growth. And then, of course, with the 2+ decades I've used them, I know our other founding member, Dr. Kelly Hale's up to about 10 years. Dr. Kevin Gold's probably about 6 or 7. Those are just 3 people I know are over 30 years using these, and I've trained another 500 offices around the country. We basically have the experience of seeing the jaws grow, the teeth land, and then a percentage of wisdom tooth eruption take place. Not to mention the fact that I don't have a single example of a child going through guidance appliance therapy and ever ending up with extractions, that's for sure. But on top of that, jaw surgery. And I am familiar in the orthotropics training, which again, it's wider and forward. And I understand orthotropics can be good for you, but I understand there are a percentage of kids that go through orthotropics and do get jaw surgeries as teenagers. And so while that's probably part of their treatment and they needed that as their end result to get into a jaw surgery, in our world of the guidance appliances, when you combine guidance appliances with myofunctional therapy, you get all of your natural jaw growth and development back. And we don't see children ending up in jaw surgery after the use. So the retraction myth about guides comes from, I'm not sure where, but it comes from a place of no research, no resources, and no opportunity to even have that be working through common sense, because really the idea behind the guides is just redelivering your breathing and musculature. So I can give you decades of, and actually I was told my office does count as research by a researcher. I used to say I don't do research because I'm a clinical practitioner, but I was recently told that I am doing research. When you're doing something for 20 years in your office, it does count as research. You can use that word. And so I would tell you my over 2 decades of research shows that children who use guides have nothing but symptom resolution and healing, growth and development enough for 32 teeth most of the time, avoid expanders, avoid brackets and wires, and certainly avoid jaw surgeries. The last item I'll add about the retractive component that, again, makes total sense is that we all know that retractive techniques cause symptoms or make them worse. You know, retraction type of orthodontics is very bad for a child. And the sheer fact that using guidance appliances eliminates and reduces symptoms almost immediately is evidence that it is not retractive. You have to be going wider and forward to deliver symptom resolution. And across the board, we have symptom resolution over my 2 decades and other providers as well. The children who come to me who were recommended to have medications never get them. And the children who show up on medications get off the medications. Bedwetting goes away, nightmares go away, digestive issues go away, headaches go away. All of the things that are related to sleep and breathing disorders start to fade. And you can't have that from a retractive technique. So that kind of helps understand that that comment might be coming from somewhere without a resource for it. And it might just be a loose opinion on 1 or 2 cases. So given the fact that a wider and forward growth approach through these guides gives symptom resolution alone should be enough that it's not retractive. And then I'll add this as a final comment. If our new standard is to find 1 or 2 cases where maybe something didn't go well, what dental technique would pass that standard? Because I can find 1 or 2 cases where a filling didn't go well. Should we stop doing fillings? I can give you 1 or 2 examples where a root canal didn't go well. Do we stop doing those? How about a bridge didn't go well? Oh, an implant failed. If 1 or 2 implants fail, does that mean implants are bad? So let's think about that standard, because I have asked and no one's provided research on that comment, and no one's provided more than 1 or 2 cases that were thrown out loosely saying that the child had a guide. Meanwhile, we have no full history on that child. And then, of course, I have also learned that those comments might be coming from people who don't have experience using the guides. So I think if we're going to have a standard where 1 or 2 cases of something not having the outcome you wanted without full information, if we're going to go ahead and say that's not a good technique or it's a bad technique, I could apply that to every single thing in dentistry going forward. And I don't mean to say it this way, but I probably could find a couple of kids that failed myofunctional therapy because they didn't do it right. It doesn't mean myofunctional therapy is a failure and shouldn't be done. So there's a long list of things wrong with that comment, and I could probably talk for hours on it, but I am more than happy to set up an individual phone call for anyone who would like to pursue that further.
Thank you. Dr. Christensen, you want to chime in on that?
Yeah, I really appreciate the chance of being in on this. You know, looking at the guides and the airway treatment that there's so many of us that are working on, you know, I'm kind of the orthodontist in the side that does things a little bit different, but also I look at the number of people that we're able to touch with our different treatments. And just like with Ben, what Ben was saying there just a little bit ago, there's no magic treatment for any patient out there. You know, even in the orthodontic world, I have failures. And, you know, it's okay to say, you know, there's failures in a practice, you know, and most of them come from non-compliance. And, you know, the guides is a compliance rich, you know, appliance. And to be successful, the cool thing about it is, and the thing that I get from this and the success of the guides and Toothpillow is getting these kids at the youngest age that you can and getting them started doing things correctly. You know, if we wait until they're 8 years old, there's a ton of their growth and development that hasn't happened, and they're probably going to need, you know, some orthodontic intervention to get them back up to the standard. But then after you get them there, what are you going to do? You know, say you treat them between 8 and 9 years old and you still have 12 baby teeth to lose. You know, you've done your expansion, you've got their airways where they're supposed to be. And like in my office, I then send a kid to myofunctional therapy, and mom looks at me and says, you know, I don't want to go through the expense of myofunctional therapy and tongue tie and everything like that. And so there's a compliance factor that goes into this. And so as we go forward with Toothpillow and things like that, you know, I don't think Ben's saying, hey, this is the magic pill for everybody. But if we can get these kids when they're very young and get them trained and get their, you know, whole function going on the right pathway, we're going to reduce the total number of patients that we have to treat in the whole world. And so, you know, if you go back to the very beginning part of it, you know, I look at tongue ties that we release, and I've released probably close to 1,000 babies. And I have little babies that come in that have treated their siblings with expansion. And then they've got this little one that's 4 years old, and mom and dad look at me and they say, hey, you know, do you remember this little one? And I'm like, no, am I supposed to? And they said, well, you fixed the tongue tie 4 years ago. And I'm now doing expansion on the older siblings. I look back at this 4-year-old and I look in the mouth and there's all these gaps, and it's got what I call the nickel's worth. There's a nickel's worth of space between all of these teeth because I fixed something in the first week of life that got the tongue functioning correctly, and then none of these other problems go. So if genetics played out, this kid should need all the stuff that the older siblings are having, yet we got something early. So as I look at what Toothpillow is doing, they're doing something that nobody has ever done. And that is they are starting early. You know, if you wait for the orthodontic world, you're going to wait until everybody's 8 years old and everybody has to have treatment. If you start them when they're 2 and 3 years old, and, you know, Kevin Boyd and I talked about, you know, other things that we could get these kids even before 2 years old to get them to start functioning correctly. You know, that is the key that I think this whole, you know, Toothpillow revolution is coming from, is getting them early enough to get them functioning at the earliest age so we can reduce the amount of treatment that we have to do. The best treatment is the least amount, not the massive amounts of things that I'm doing every day. I mean, I saw over 80 patients today doing massive skeletal craniofacial growth and development. So there's my take.
Thank you so much. And we really appreciate you being here as a board certified orthodontist. How many years, Bret? I don't want to
Oh,
age
God.
you, but
I've been in dentistry for a long time. I'm the only really white-haired guy in this group. So, I mean, I've been doing this for 35 years. So,
yeah, thank you. Dr. Boyd, you want to chime in on that? I know we're talking early intervention. That's your sweet spot. You're just on mute. So you can come off of mute.
Yeah, I was just pointing to my white hair. He's not alone. But
You got
anyway,
the
the first thing that I'd like to say about the person who asked the questions about retraction, and that reflects a great deal of knowledge. Can you hear me?
Yes, very,
Oh, I'm hearing somebody's unmuted. Anyway, that person who asked that question, I'd like to point out they have a lot of knowledge and they have sincere concern because they don't know. I mean, when I first learned about this, I had no clue what Toothpillow was. I thought it was something that kids would rest each jaw on, a pillow. And, you know, I've since delved into it. And so there's a great deal of curiosity about this, but lack of knowledge. So that person who posed that question, I don't think, I just think that they want to know because they've learned a retracted jaw doesn't need more retraction. And obviously, if they understood Ben Miraglia's journey and how he may not have been a direct student of John Mew or Bill Hang, but he certainly has mastered all of the knowledge that they've, that John Mew and Bill Hang have been teaching so many of us. So anyway, I'm just really glad that was brought to light, and I think Ben answered it, correctly. The amount of time that these things are worn, even if they were retractive, they couldn't do much damage because they don't have to be worn that long. And another thing, just in listening to this, I was reminded in my office in Chicago, next to my dental degree, is my sailing school diploma from 1966. And I grew up in Michigan on a small inland lake. And one of the things we did in our small little butterfly scow sailboats, they were 12 feet long, is that you would have to read the wind as it was away from the shore and where the ripples were. And you would have to row or paddle or get behind the boat and, kick, stroke, and get out to the wind and then raise the sail and let it take it away. And I thought this is a perfect analogy. Is it, these guide appliances, whatever, and as we start to work younger and younger and younger, this is the work. This is the getting the sailboat out to where the wind is and then hoist the sail and let the masticatory apparatus take over. That's what happened for all of our existence as humans. So anyway, I'm just thrilled to be part of this. And that's all I have to say about that.
Well, we're thrilled that you're thrilled to be part of this because we're thrilled to have you, especially and to Dr. Christensen's point, we are going to focus on going upstream in the future. I don't know, Chad, do you want to speak to that a little bit, or Ben, even just kind of out of the box, forward thinking? And another question was about what about the adults as well? So maybe just a overview of your vision.
So when we first launched the company, the age that we could address most comfortably with these types of treatment plans was ages 3 to 12. But we knew that we didn't want to just wait until a child was 3. It's like they develop the poor function early. And so why can't we intervene early? And that's why we're so lucky to work with amazing doctors that specialize in that age demographic, such as Dr. Kevin Boyd or Dr. Billy Arnold and many other. Dr. Liz Turner is a great friend of ours, just trying to find out what is the best intervention for that early age, and can we offer some type of better access to that treatment between ages, from birth to 3. And so hopefully we'll get there. Our goal is to launch something there in the next several months. And then same thing with teens and adults. And now none of this do people have to wait for us. Like if somebody suspects that there is a patient that is suffering with suboptimal growth, poor oral habits, malocclusion, whatever it is, get treatment right now. By no means wait for Toothpillow. Go into an office where there's highly trained providers today. And that goes for the adults as well, the teens and the adults. Now, we do think that there's a way that we can make teen and adult treatment more accessible as well. We've started a pilot program actually in some markets right now where we're testing that. Can we provide high quality care through this kind of virtual approach. And so we're more, that's one that should be coming a little bit sooner. But again, don't hold your breath. Breathing is important. So get into an office and get treated.
We also have Dr. Cassie Klein with us. We have a few more minutes. Do you think we should just have her share her experience of being an actual premium provider? Because there's so many questions here that we may just have to have another Q&A session, because I really want to make sure we don't go over. But let me see if I can bring her
and while you're bringing her on,
Mm-hmm.
again, just to everybody that's here, you don't need to utilize Toothpillow. Like, if you want to offer these treatments in your practice, you can go to the same vendors, suppliers that are providing appliances to us. You can source those directly yourself. Again, we mentioned some, MyoBrace, Vivos. Other people have used Healthy Start with great success. So there's other great appliances that are out there and tools that you should have in your toolbox and offer these treatments. And that is the case with all the 70 dentists that work with us, 70 plus dentists that work with us, including Dr. Cassie Klein. She was doing this in her practice before Toothpillow was ever even a business and an idea, for that matter. And then where we came on, so she's already offering these great treatments, and then she's kind of wrapping those treatments with this Toothpillow experience, leveraging our unboxing experience, our virtual support team, our app. And so she's still doing that in her office, and we call that a prime location, where she's delivering, let's call it Vivos treatment wrapped in Toothpillow to her patients. And everything is kind of done by her, but leveraging some of our virtual tools or our digital tools for that. And Dr. Cassie is an amazing doctor. And we're honored that she works with us and helps with some virtual care side, but she was doing amazing things already before Toothpillow was even a thing. But why did you choose to be a prime location, Dr. Klein?
Yeah, you can just come off mute. Thank you.
Thanks, Chad. Really, I mean, kind of like you said, I've already been doing this for a long time. I've been using the guides and my own children and hundreds and hundreds of children in my clinic. So when Toothpillow came along, I was able to join as a virtual provider, and then saw what a benefit it was to use the app and keep the patients motivated. They love the box and the packaging and everything. And then for them to be able to walk out of my office with that box the same day and still get that virtual Toothpillow fun experience was, I mean, it was a no-brainer. I was so excited. And I didn't know how many support team Toothpillow had until tonight. And I wrote it down, but it's like my team grew by like 40 members, right? So all of these patients that I'm taking care of with my, with the guides and Airway and everything, we have the awesome support team behind us to answer questions, and the patients just get such an awesome experience.
Yeah, thank you. And hopefully reduce your, because there is a lot of, if you're going to deliver treatment to your patient, then it is expected that you're following up with them. And so by leveraging a virtual check-in and eliminating some of the in-office follow-up, that just allows you to go and have more time for new patient consults or other types of treatment. And so it's really just trying to empower you to be able to, take out some of the things that are burdening you so that you can go out and help even more patients. So that's how we help those. Somebody else I saw message in, say, I already offer these types of appliances. How can I, what's the value of me working with Toothpillow in that case? And it's just that help leverage the technology that we have.
Sorry, Chad. It made a huge impact on like the amount of patients I'm able to see. We want to help and see as many patients as possible. And because I have the extra support, I can do other things, see more patients too. Just like you said.
Thank you so much. And I know we're coming up at 9:31, so we are at time. And I'm a stickler for time because I just want to respect everybody's commitment. So we appreciate you being here. I do want to just announce about Airway Health Solutions University. Please check out our website. We have great updates and some great new courses and electives. So it's a fall semester. You can still join us on demand. So also want to save the date for Airway Palooza and register. We actually have 50 registrants already. So I know this will be sold out again. So please take advantage of our lowest pricing of the year. We will be raising the pricing on November 1st, and we hope you can join us for the celebration. Look more on our website for more information and the videos on that. We also there's more resources at the Children's Airway First Foundation for help with patient education. They have great resources and podcasts. And I want to just announce our free masterclass with Dr. Mike DeLuke next week, October 23rd at 7 p.m. That'll be 2 CEs. And Dr. Christensen, we actually want to invite you back on a panelist for that. So I didn't have a chance to ask you, so I'll figure out this ask you right now. You can get back to me at another time. But I'm so thrilled for this evening and just all the questions that we're able to answer. Again, if you want more information, please give us your information so we can reach out to you. But I also want to give a shout out to Toothpillow's Instagram. I always recommend that for patient and parent information. The testimonials are wonderful and just doing such a great job at raising awareness. So the marketing team is really phenomenal there. And you know, we have to get this to the public eye so they can actually make the demand. And we're hearing it. I'm feeling it. I know a lot of people are hearing about Toothpillow. They're asking me, they're going to be asking you. So hopefully this helped you all better understand the mission and just how we can help more people breathe, sleep, and thrive together. So if you have any other questions, please feel free to reach out to Erin@toothpillow.com. I'm going to put Erin on charge for that, or you can always email me at info@airwayhealthsolutions.com. Chad, I'm going to have you close this out because I know this is your baby, and I'm so you know, proud to be part of this team and help you drive this forward. So why don't you close this out with just some motivation of the future? And it's right. No pressure.
Awesome. Well,
go for it.
Thank you again, Lauren, for hosting tonight, for putting this together, for the hundreds of people that have been on. It's such an honor for us to just share this with you. And again, I want to thank all of you guys for taking charge and going and wanting to bring the airway conversation mainstream to so many patients, because I know that it can help. So as we leave this call tomorrow, just start talking about it with patients. You don't even have to talk about Toothpillow. I'm not saying that. Just talk to them about an airway issue that might be related to their jaw issue, you know, jaw development, all that, because it has such an impact on their overall health, their quality of life, and those things. And you hold the key. You might be the only one that brings that conversation up to them in the next 10 years. I know that nobody ever brought it up to me in 40 years. And so please, I'm just you know, have the courage to go out and share this. You can literally change a life and in all reality, save lives by doing so. So thanks for being here tonight. And we hope to be able to work with as many of you that would like to, again, dentists, hygienists, myofunctional therapists, and beyond. So you guys are lifesavers. Have a good night.
Great. Thank you, Dr. Miraglia, for sharing your wisdom. Thank you, everyone, for joining us tonight. And we'll do this again because there's plenty of questions. So as long as you keep asking, we'll keep showing up. So thanks, everyone. Have a great night.
Good night, everybody.